Thanks.
Thank you, Connie. Great job of covering everything. So let's get started. You guys know the MUI rule has gone through some revisions. We're going to talk about kind of that. We're going to talk about the vision behind some of those changes. I'm going to talk a little bit with you about the review process because we had a tremendous stakeholder group that helped us take a look at this rule this time and recommend the changes that we've adopted that we're going to talk to you about today. We're going to talk about those specific changes and a little bit of background on what happened with those. And then we're going to get into the actual changes throughout the presentation today. Following that, we're going to discuss some timelines. When is everything going to be effective? What's happening? And then, as Connie mentioned, we've been really working hard on some resources, and we'll talk to you about some other options for trainings, trying to make sure that we get everybody trained and ready to go for our start date, which is going to be July 1st. So, we've got a month or so before this is going to kick off, and we've been doing a lot of training, having a lot of conversations. We've done a road show of in-person trainings along with some other virtual trainings just like this one today, really trying to get the word out and to try to share information so that we're all well informed prior to the July 1 deadline. So, all right, next slide there, Dustin. All right, we're going to talk about, this is a kind of a step through some of the considerations behind the rule. And the first and foremost, and you guys all know this, all the conversation about our rule is about how can we have the best critical incident reporting system in the nation. And I know I'm biased, but I will tell you guys that Ohio is a leader, is a best practice in terms of MUI critical incident reporting systems. We are fortunate enough to have a lot of conversations with a lot of different states. And certainly I feel really comfortable that we have a tremendous system in Ohio, and it's because of the folks that are on this call today. You know, if we don't have a good system where people understand what to report, how to report, we take a lot of time to look into what's happening to protect people. You just don't have a quality health and welfare improvement process like we have without buy-in, support, and certainly collaboration at all levels of our system. And so thank you again for all the work that you guys do. And again, for being here today to get the information you need to continue to keep us where we need to be. The good part about pulling a rule group together, as we did this time, was, as I mentioned, everybody wants us to have the very best system possible. So we start from there. But then certainly if you get county boards and providers, individuals and families, stakeholder groups, the department personnel together to talk about this, not everybody maybe agrees with exactly the way that we do that. What's the best way to have the best system possible? But we've had some tremendous dialogue, some tremendous conversation. And I think we landed in some really good places, and we're going to walk you through those changes today. Back one more slide real quick, Dustin, until we get through. So the focus is going to be on quality and prevention, and we want to make sure we're going to talk to you about that. You're going to hear a lot more about collaboration between provider, county board, and department today as we walk through some of the changes. And it's something that really took a lot of conversation time during the stakeholder group, and we're excited about it, and we think it's going to be good. That's going to allow us to improve our consistency among our stakeholders. As Connie mentioned, Chris is going to talk about the appendix forms, which is a big change for us during this rule, and one that I know you guys are certainly wanting to find out more about, and we're going to share more about today. The conversation about that also was related to resources and trying to reduce administrative burden. And so you're going to see when we talk about some of the changes how, some quicker action can be taken, some quicker communication can happen, and it's going to cause us to really collaborate with our business partners throughout the system in ways that we didn't sometimes in the past. And we're excited about that too. I think it's going to be certainly a change and a learning process, but we think at the end of the day, it's going to really give us the opportunity to provide better quality services and support people and protecting their health and welfare. And then the last thing we're going to talk to you about, and you're going to hear several of us during the presentation today talk about the CMS access rules. And I'm not sure how many of you are familiar, but CMS is basically defining for all the states in the nation about what will be in a critical incident reporting system. And the good news there is that Ohio is in a really good place. When we took a look at what CMS shared related to the access rules involving critical incident reporting systems, Ohio was in really good shape. Probably already have about 90% of what they're asking for in our current system. But there certainly were some changes and are some changes that are going to need to be made. And we're going to talk to you about that today when we share some of the category changes and some of the updates to language within the rule that we did based on, primarily our CMS access rule information and what we need to do to get ready for that when those responsibilities become requirements. So, all right, Appreciate it. That's the next slide there. The process itself, I told you we had a tremendous group. For those of you that don't know, every administrative rule that we have receives a 5-year review. So the MUI rule has gone through several of these, and these are some of the folks that were on that committee, a tremendous group. Really, there was nobody that within our system that was not represented, that was able to have a voice. And we had some tremendous conversations about each section of the rule that we went over. So, and not only do we have those folks that you see listed there, but we also, this time around, we had our DODD physicians actively involved, and primarily our medical director, Dr. Sorg, took the lead and was very instrumental in helping us talk about particularly the unanticipated hospitalization MUI category that we're going to go into some detail about today. We took a look at our MUI data related to hospitalizations. We got some feedback from physicians and certainly from all of our stakeholder group, and it allowed us to land what we think in a spot that's going to give us a good opportunity moving forward to continue to improve in the way we monitor unanticipated hospitalizations. We also got some information from other states. I'm a firm believer that you don't have to always recreate the wheel. If somebody's doing something well, we'd like to know about it, and we'd like to try to do it. So we were able to get some information, California, New York, a couple other states that do some really, really good work. So we certainly ran this information by them and looked at how they handle some of this information to make sure we're in good shape. We also talked to our various stakeholders along with all of our business partners, as I mentioned, and you see the group that's represented. We really got some tremendous feedback and had a lot of good conversations prior to making any of the rule revision changes. Next slide, Dustin. All right, here's the QR code. I think Connie mentioned this earlier on, but this is the QR code for the actual rule. So you don't have to go searching for it. This is the revised rule that will be effective July 1. Along with the appendices, you can scan it, and you've got immediate access to that revised rule. All right, some of the purpose of some of the changes, and I want to take just a few minutes to talk about this, is there was a lot of conversation about the MUI process and the specific outcomes. And what I really want to focus on today is talking about how we can make that a positive culture. I know sometimes, and let's be honest, some of the MUIs that happen are tough. Sometimes people make decisions that are really bad, or sometimes people get abused or neglected or stolen from. And certainly, our system has to take action and has to move forward and do that. But other times there's MUIs that are reported where, sometimes people make mistakes and things happen. And our system is not unlike any other system. It's not a perfect system, certainly. And sometimes things happen. And what we want to talk about is trying to make sure that our investigatory process, our follow-up, our quality improvement thinks about that and comes up with cause and contributing factors and prevention plans that allow our system to continue to move forward, understanding that, the primary goal for our MUI system is protecting the individuals that we support in Ohio, but that includes the support of those that are providing services and how we can support our direct support professionals and our managers and our folks that are really working hard every day to try to get the job done and protect people. And so you're going to hear some conversation about, how we can do that. And, what does that really mean? It means that we got to work together collaboratively. We got to make sure that certainly if there's someone that shouldn't be working with someone, that happens. But if there's somebody that's making mistakes and just needs some training and can follow up, that we try to do that as well. So I think we're going to talk about that. And when we think about, next slide, Dustin, when we think about quality improvement, this is kind of some of the stuff that you see. And what we don't want to have is people thinking that the process is like the items in the left. Because I can tell you, and I've worked, with the MUI unit for a long time. We work locally with the MUI groups at the boards, and all of you that run provider agencies, that our MUI process is about quality, health, and welfare improvement. It should never be about shame. It should never be about blame. We should never try to be punitive unless it's, necessary for certain kinds of cases. And we want to make sure that everybody understands our system, understands the outcomes. One of the things I'll tell you is we had several direct support professionals that were on the committee this time, and they gave us some really good feedback about what could we do better to help support our direct support professionals through the MUI and the UI process. And you're going to hear from us in some of the presentation today about what we talked about and what changes we've made to the rule to try to make sure that we're doing that. We're talking about training and tools, making sure those are available. And we want to make sure we communicate well. Some of the feedback we got in the committee was that sometimes the communication about an investigation or the follow-up related to an investigation, that sometimes maybe we don't share as much as we could or we should. And so we thought about that, and we've again built in some information within the rule to talk about that. And what we really want to see, those items to the right, we want to see really good root cause analysis. And for those of you that may not know what that is, that's really taking a look at the true root cause of why something happened, not just reporting it and trying to stop it, but why did it happen? What led up to it? What were the causes and contributing factors leading up to it to try to get to the true root cause? And we also want to look at how we process cases through our system, making sure that everybody's informed. We certainly have to be accountable. We got to make sure that we're accountable for what happens and that we take ownership in trying to assure that we prevent those things from happening again. And you guys know that the MUI process is an ever-changing process. We're always learning. We're always improving. One of the reasons that we have one of the best systems in America is we've worked really, really hard, and you guys have worked really, really hard to identify health and welfare issues and put good systems into place to prevent those things from happening. We've built a safety culture unlike any other, but we got to count on open communication, and certainly we've got to treat each other respectfully throughout. And if we do that, we're going to continue to move forward and have our continuous quality improvement loop, which is really what this MUI process is all about. So with that said, that gives you a little bit of background on what was discussed, a little bit of information on what you're going to see in terms of some of the changes as we get to them here. And I think with that, I'm going to transfer this over to Chris Young to talk a little bit about administrative investigations and the new administrative reviews that have been added. So Chris, you want to take over here?
Absolutely. Thanks, Scott.
You bet.
As Scott mentioned, the committee had a lot of good discussions on how to improve consistency and efficiency. And one of the first things you will see in the new rule relates to this slide here in administrative investigations and administrative review processes. Go ahead and next, there we go. So MUI process is streamlined. So administrative investigations includes all the A and B categories, which the IA would complete the investigation so the cause contributing factors and prevention plans can be developed. Same process. For the administrative review processes, it changes a little bit. So they will still consist of the same C categories, which is the law enforcement, hospitalizations, and unapproved behavior supports. With this process, there will be more of a collaboration between the person's provider, the county board, and the IA, along with the person's team to develop cause contributing factors and prevention plans. And Scott mentioned a lot about that collaboration. This is really where the collaboration begins as part of the new rule. So for those category C MUIs, there will now be a required associated administrative review form to be completed. The form will have questions specifics to each category type and will be completed by the provider and by the county board IA, which will then be used as the MUI report for ITMS. So there will be 3 mandatory forms. Law enforcement cases will now be completed using the Appendix C form. Hospitalizations will be completed using the Appendix D form, and unapproved behavior supports completed using the Appendix E form. Next slide. All right. So the provider will also submit the administrative review form in the Appendix C, D, or E, and the provider will submit the incident report and the administrative review form at the same time. So 2 very important bullet points there. So again, the person who witnessed the incident should always be writing the incident report and sending to the appropriate person at the provider setting. Just the same as you've been doing for all these years, right? Person that witnesses writes the IR, sends it to the appropriate person. The IR will then start the review process. The provider can then decide who will complete the review form, which may be maybe the home supervisor, maybe the home manager, director, whomever that provider decides. The review form and the incident report is then to be sent to the county board by 3 p.m. the next working day. Again, same process as it relates to those time frames. With this administrative review process, the committee felt with the provider knowing what occurred and knowing the history, supervision, and so on of the involved individual for those law enforcement, hospitalization, and UBS categories, along with all 88 county boards doing it the same. Let's face it, a lot of times Cuyahoga may be doing it different from a county and possibly Hamilton or across the state. So this way, all these forms will be completed the same route, and it will also help streamline the system to be more efficient and consistent. Also, with the provider starting the review form process, the hope is to also allow the IA to prioritize more on those A and B cases. And again, that was a big discussion by the committee as well. Hopefully, and it is believed that this process will allow the IA to, again, provide some prioritization more so to those A and B cases. And then, therefore, for providers that may have staff on leave due to A-type cases, they may be able to get staff back to work more promptly, and the team may start the prevention planning more promptly. When a person is hospitalized, that's kind of this last bullet point here. When a person is hospitalized, the provider is responsible for following up with the hospital so that a diagnosis is determined as soon as possible after 48 hours. An IR is made to the county board, and the review form in Appendix D, which is hospitalization to this rule, submitted when the situation meets the definition of an unanticipated hospitalization. So whether it is a UI hospital stay or meets MUI criteria, again, that's admission lasting 48 hours or longer. We want providers to continue being that main point of contact once the diagnosis is determined and after the 48 hours admissions. Again, the IR and the form will then be shared with the county board. All right, next slide. Perfect. So this form here is the first form that we'll talk about, which is the Appendix C, or the law enforcement form. This form has a lot of similar questions as the current rule, Appendix C. On each of these three forms we'll talk about, the top portion is completed by the provider as identified on the form, and the form and the incident report is then shared with the county board, again, by the next day after discovery. The IA then reviews the form to ensure they are properly coded, finish out any remaining questions, and work with the team on the concentrating factors and prevention. At the top of the form, the provider will enter the individual's names. As you'll see there, you got the individual's names, the dates, person, and position of who's completing the form. One thing that you probably will not know is that MUI number, so don't worry about that. Go ahead and send it to the county board, and then once you get the MUI number, you can indicate it as at that point in time. As the provider, if there is a certain question you may not know, please go ahead and send the required documentation to the county board and share that you are still awaiting some details. Again, this is a new process, and we want all involved entities to continue working together so the forms are completed thoroughly and accurately. Part one, again, to be completed by the provider. You'll see the description of the incident that kind of starts this process off. This will likely come directly from the incident report. So, like we've said in many trainings, that incident report is key. So please ensure that those writing the incident reports have a clear, detailed description of the incident. Then there are questions on what led to the incident, supervision, etc. So before the IA continues with part two questions, including completing the concentrating factors, a summary and conclusion based upon information obtained, such as for this type of category for law enforcement, the individual went to court per se, and the outcome is now known. Once the IA gets the form, include that in the summary and conclusion section. And then then you'll be entering the team prevention as well. All right. So as a reminder, each of the three forms are required. And for law enforcement, if the person was with the provider is responsible to complete the incident report in the form. Remember, so for law enforcement, that's one of those cases you don't have to be with a provider, right? So if the person does not have a provider for law enforcement, the county board would then be responsible to complete this process. Both the incident report and the forms are to be sent to the county board at the same time, again by 3 p.m. the next working day. I will go ahead and share that throughout the trainings that we have had, one of the questions we do get is, do we need to send an incident report if we're doing the form? And the answer is yes. And again, As I mentioned previously, always remember the incident report is written by the witness to the incident, as the review form may then be completed by someone different. So again, please ensure both are completed. All right, Appendix D form, unanticipated hospitalization. Here you will see the hospitalization form. Again, the provider will start the process with the incident report prior to completing the form. For hospitalizations, there are two situations that will meet hospitalization criteria, which kind of we'll discuss here in just a little bit. But um, this is also explained in this first section here. You will see under the description, and the provider will check which situation applies. So there's kind of two situations for hospitalization. As you will see, there are questions of how the person was doing prior to being hospitalized. If you scroll down, so again, please ensure there are descriptive incident reports being completed, which will help answer much of those questions on the form. Once the forms, once the provider starts completing the form, if the incident report was not clear or the health of the person leading up to the 72 hours was not known, for example, let's look at those case notes. Let's follow up with the staff present if needed to assist in completing this form prior to sending it to the county board. A key element for any hospitalization, and I'll probably stress this a couple times, but always, always, always try to get that hospital discharge summary. So providers, please remind staff that assist in transporting the person home to ensure they have the discharge paperwork prior to leaving. This will help the provider and the IA tremendously in the completion of this form, and also assist in good prevention planning. Right. Part two of this form also includes a summary and conclusion section. If the provider wasn't clear on some initial part one questions, this may be a good area to include any of that follow-up. Again, continue working together on any questions or information that is not clear as you do now, and note any concerns or possibility if a further category is needed to be filed. That's a good area to include that. Again, the incident report, Appendix D form, discharge paperwork to be sent to the county board by 3 p.m. the next working day. If the person is still hospitalized when you send an incident report and form to the county board, please ensure you're still obtaining and sending that discharge paperwork to the county board once received. So again, Appendix E form, same type process moving forward. Again, please ensure that the obtained incident report is descriptive and respond to each question as you go through this form. The provider will complete much of the form with the IA reviewing and following up on cause stream factors and team prevention. So this final unapproved behavior support slide, again, just the same reminders we wanted to include on each one relating to what needs submitted and the time frames. Part one, again, completed by the provider. Part two, as you scroll down, is completed by the county board investigative agent. And again, we want to make sure that you guys work together on this form. It's really, as Scott mentioned, this is really a very key element in what the committee spoke about in regards to collaboration. And these forms are just an example of that collaboration that we know will continue to be improved upon as we move forward with this system. So also, I'll just put this out there too. We are working on some completed time templates for examples for each of these three forms. And once we do get those, we will also house those in the department's website for your review. So with that said, I will pass it on to Dustin.
Thanks, Chris. I'm going to start with looking at some of the changes with definitions and some of the updates. And a lot of these are predicated on access rule changes. And so we kind of think about the shift here. The most obvious would be we're moving from verbal abuse to emotional abuse. And again, that was geared towards access rule changes. And so kind of think about that throughout the presentation, as a lot of these were kind of in alignment or trying to be in alignment with those rules and regs. And so we look at emotional abuse. The big change here, outside of the actual name change, is that we replaced, again, verbal abuse with emotional abuse, and we added in red here a pattern of behavior that creates a hostile environment. So nothing changed with the definition outside that we added some additional information. We understand that obviously this is a big change, and we're all going to be navigating together as 7-1 comes and beyond. And just know that we're here to support you in every situation, always, in that, we're going to continue to learn about how to interpret things as we kind of come across them as well. Just kind of thinking about pattern of behavior that creates a hostile environment. We've had a ton of questions on what does that mean? What's that look like? And so kind of keep in mind of, those instances where, bullying may be present. We've had some good examples, and we're going to show a few here in just a moment. But one that comes to mind is, someone is afraid of the dark, and it's well known, and staff keep turning out the lights, and that person is very upset by that. We know that. That would, demonstrate a pattern of behavior. That staff person or individuals involved kind of ignored the situation and persisted to engage in that pattern. So kind of think about that as we kind of move forward into the rule change here, and as we're all going to be navigating together, and we're going to be in it together and learning together. Again, some of those examples that stem from emotional abuse, and some of these are going to sound, very clear cut, right? So a person alleges their father threatened to punch them if he did not do the dishes. We kind of think about intimidation there, coercion. We think about the next one here, staff taking an unflattering photo or video of a person and posted to social media. Definitely not okay. We look at humiliation there. And then the home manager sprays a person in the face with water as a way to coerce them. And it's right there in that example is a form of coercion. Then we kind of move into a bigger example, I think, that speaks a little bit more to the added version or verbiage, pattern behavior and hostile environment, is a staff member works with a person, and similar to the dark, being afraid of the dark, this person is sensitive to loud noises. And so despite being trained and repeated reminders by folks, we're slamming doors, clapping loudly, nearing this person and causing them to flinch or cover their ears in distress. And this would demonstrate, a consistency of behavior that the person, obviously is not fond of and not okay to engage in. And we see that person who's being affected, visibly anxious, withdrawn, upset by staff. And the staff member, in this case, dismisses the concerns by saying, "Hey, I was just joking around," or "that person's too sensitive." In terms of a pattern of behavior, intent is irrelevant here because we're thinking about the behavior. It is consistent in creating a pattern. So kind of think about that as well. When we move into failure to report, really what the changes here is to provide further clarification, which is spelled out in red here. And so when we think about failure to report, they're going to be tied to these specific areas. When we think about failure to report, we're looking at emotional abuse or any of the abuse categories, exploitation, misappropriation, and neglect. And so when we kind of navigate these situations, or really all situations, we want to keep in mind the difference between failure to report and late reporting. The difference being is the actions taken to mitigate the risk, or the immediate actions to kind of start the response to an incident occurring. And so, it's really important to know that, because oftentimes we think, when we kind of hear about it after the fact, is we kind of forget that there might be actions that have occurred to mitigate that risk. So we really want to focus on that. We want to focus on the risk. Another thing to kind of keep in mind, though we're focusing on these specific categories, we kind of think about our UHs or UBSs or any of the others. We want to also, again, think about the risk, think about the actions, and there might be situations where, it wasn't so much a failure to report. Maybe that's a component, but maybe we had neglect as a result instead. So we're trying to focus again on these specific categories. And again, really the focus here is mitigating the risk when we think about failure to report versus a late report. Category B changes with deaths. This really didn't change outside of we renamed the categories. And the reason for this was, again, to align with CMS language. So we had non-suspicious, suspicious, and now we've kind of moved to unexplained or unanticipated. And then the other change here is death other than explained or anticipated death. This process remains the same. We have a good group of folks, our mortality, and lots of doctors who participate that who do an amazing job looking at these cases. And they have good questions. And the folks in the community, you guys in the field, always get back with all the right answers and good information to help us through that process. So again, nothing's changed here other than just a name switch. Category B changes with medical emergencies. So what happened here is we clarified medical emergencies are filed only when completed by a DD employee. I believe this was already kind of best practice, and we had that information in motion. We just further clarified it and made sure it was identified in the rule change. We also removed the use of EpiPen from the definition. And the thought process here is that a lot of folks know individuals very, very well, and those might be addressed in a admin record or have those already on hand, and folks are navigating those situations really, really well. And the other part here, data always drives a lot of the changes in our perspectives, right? And so we added the use of overdose reversal medications. So those Narcan situations. So again, the big changes here to identify more clarification, DD employee intervention, and we added some information about overdose reversal medications such as Narcan. Keep in mind, we're not asking providers to have Narcan on hand. We're not necessarily be trained on that, but in the odd chances that those items are used again by a DD employee, they meet the definition of a medical emergency. Category B changes for missing individual. All situations, whether they're UH, missing person, a neglect, we're going to look at them with seriousness, right? And we're going to keep those biases at the door. For missing persons, we really tried to hone in on the more serious cases. Again, not saying that these couldn't reach that level, but we kind of think about those situations where law enforcement has been contacted and the whereabouts of the individual is unknown, and we think the person is at immediate risk to self-harm or to others. We've been telling folks, if law enforcement needs to be contacted, we absolutely need to make those phone calls, get the right people involved. So we're not saying, hey, if a person goes missing, we're only going to call law enforcement if they're at immediate risk or harm. There might be situations where there's still contact, but maybe that immediate risk maybe didn't rise to the total level of an MUI. And so we want folks to keep in mind that this is not to deter us from calling law enforcement in situations that we need to get them involved, crisis situations and all they're after. So we're really trying to hone in again on being a little bit more specific on the serious causes here. And with ISP times missing, again, those are factors, but we really want to focus on the immediate risk of harm to self and others. And again, was law enforcement contacted to help us out with locating an individual? Category B changes peer-to-peer. The big one here is we removed verbal acts from peer-to-peer, and really the thought process there is folks are doing a really great job out there and kind of getting involved, getting those resolved quickly, and those could be a quick escalation between peers or folks and saying some not so great things. And we saw that the immediate actions and the time and resources spent were really, really good, but I think, again, the way we're supporting folks and mitigating those situations, it made good sense to remove this from the peer-to-peer categorization. So what we have then left with is the exploitation, theft instances, physical acts, and sexual acts. One thing to remember, if there are instances where maybe peers have, had verbal interactions that rise to a level of maybe harassment or an unfavorable situation, though we're not categorizing as verbal abuse, we should support those folks in seeking the help and guidance they need, whether it's through that team process that everyone's really, really great at doing, or involving, say, law enforcement. And there might be considerations of, say, menacing or other activities that we want to make sure, again, those people feel healthy and safe. Again, though we're not dressing as an MUI, doesn't mean that we want to support a good outcome there. Category B changes with significant injury. So a big part here is we removed a part of a definition that was not considered abuse and neglect, and we added dental injuries requiring treatment by a dentist. And again, we had this outlined in the interpretive guidelines and FAQs, but now it makes its way into the definition. It's a little bit more clear cut And in conjunction with adding the dental injuries that require treatment by a dentist, we still have those areas: concussion, broken bones, dislocation, second, third degree burns, and so on. So the big change here is, again, not considered abuse and neglect, and we added dental injuries requiring treatment by a dentist. And with that, I'm going to turn over to Connie to talk a little bit more about the Category C changes.
Thanks, Dustin. So we're really excited about some of the new changes with the MUI rule, specifically around unanticipated hospitalizations. We've had a lot of discussion as with lots of our different stakeholders about the best path forward, focusing on people's mental and physical wellness. And so we spent a lot of time talking about this in our rule committee. And where we landed, it was we wanted to take into consideration, first of all, the CMS access rule changes. So we wanted to align our rules with the rest of the requirements through the access rule. We wanted to focus on the most serious types of hospitalizations, and also we wanted to focus on readmissions. So most of you know that about 1 in every 3 MUIs that are filed currently, which was well over 7,000 last year, are due to hospitalizations of the people that we support. So obviously, anytime someone is hospitalized, whether that be me, you, someone that we serve, it's a serious issue. And we want to make sure that we're preventing hospitalizations as much as possible, knowing that the people that we serve, some of them have ongoing chronic medical conditions. So we also wanted to take into consideration the different and precious resources that we have. So we know that if 1 in every 3 MUIs is a hospitalization requiring a MUI investigation, that takes a lot of time on behalf of the provider and the county board, the COG, and the developmental center. And we wanted to look to see if there was a better process that we could put in place, knowing that we have tremendous providers out there who are doing great work around coordination of people's medical supports. So we wanted to focus on that. In addition, we looked at data, we spoke with our physicians and nurses across the state, and we wanted to focus on the conditions and diagnosis that most commonly impact the people we serve. And so we looked at an area called the Fatal Five, and those are often referred to as the most prevalent conditions that result in illness, hospitalizations, and death for people with intellectual and developmental disabilities. They're also referred to the most preventable health conditions, the most life-threatening of those conditions. And that is true of people with IDD, not only in the US, but across the world. Many studies have been done to show that these 5 conditions result, again, in the most hospitalizations and deaths, and often they're preventable. And so those 5 conditions or diagnoses are aspiration pneumonia, dehydration, seizures, bowel obstructions, and sepsis. And we certainly saw this true of the data that we look at every year for hospitalizations and deaths, that the people we support die most of these 5 conditions we just listed. And that is true across the state and across the nation as well. So we wanted to focus our efforts on how can we prevent that from happening, knowing that those impact the people that we support the most significantly. We also added one additional diagnosis in there or condition, and that's a medication-related error that results in hospitalizations. And we did that to align with the access rules. So again, we wanted to focus on the most preventable types of hospitalizations and deaths that impact the people that we support. We wanted to focus on readmissions and also wanted to reduce some of that administrative burden when it comes to those types of MUI investigations. And that's why the hospitalizations are considered an administrative review, like Chris said. So if we go to the next slide, we'll talk about the revised definition, and we'll go over some examples. But the definition for unanticipated hospitalization is really put into two parts, part A and B. So if you look at part A of the definition, we talk about a hospitalization lasting 48 hours or more that's not planned and is due to one of the following diagnoses. So again, aspiration pneumonia, bowel obstruction, dehydration, medication error, seizure, or sepsis. So for this part to be considered a hospitalization under Part A of the definition, it has to be a hospitalization lasting 48 hours or more. It has to be unplanned. That's the second part. The third part is it has to be one of these following diagnoses. This is not to say that other types of hospitalizations are not important or significant. They absolutely are. But we are focusing our efforts on these that we know are the most prevalent and the most significant for the people that we serve. So for part A, I'm going to talk about it, just go over it one more time because this is new for all of us. For a MUI for unanticipated hospitalization, it has to be lasting 48 hours or more. It has to be unplanned or unscheduled. And the third part of this definition is it has to be due to one of these 6 diagnoses. So it's aspiration pneumonia, bowel obstruction, dehydration, medication error, seizures, and sepsis. You know, currently in our rule, there is a provision that says if a person has a chronic medical condition, such as epilepsy or something similar, we can write into their Ohio ISP how that is being coordinated, monitored, treated, how communication is with the team around that. And then an MUI would not be filed for that person's hospitalization. That is no longer the case. There is no provision in the rule that allows you to write into someone's Ohio ISP that they have a chronic condition and therefore these 6 different things would not be filed and investigated as an MUI. These 6 types of diagnoses or conditions will always be filed and investigated as an MUI for a hospitalization if they last 48 hours or longer and they're unplanned each and every time. So again, we don't have that provision in the rule. That is something that is new. The second part of the unanticipated hospitalization definition is for readmissions. Again, the committee thought it was really important that we focus on people that are going back to the hospital for the same condition repeatedly. And we want to make sure that we can prevent that. So making sure that they have the coordination, maybe the supports they need in place, they're getting that medication that was ordered timely and follow up with their physicians. So part B of the definition says a person that an MUI would be filed and investigated for a hospitalization if a person is hospitalized and it's not planned and it's lasting more than 48 hours, and it could be for any diagnoses. And then that person is readmitted within 30 calendar days of that previous discharge for the same condition. We're going to go over some examples, but again, I'll restate that because it's new. So a hospital readmission MUI would be filed or reported is if a person is hospitalized for 48 hours or more for the same condition within 30 calendar days of the first discharge. So we know that that's a little bit confusing, and all of these different hospitalizations are going to be new for us. So we're going to give each other grace as we go through the transition process. But we'll go over some examples because I think that will help best illustrate each of these different types of hospitalizations. So the first one, Janet's hospitalized for more than 48 hours due to seizures. Her Ohio ISP appropriately describes that she has epilepsy and she's regularly seen by a neurologist. This would be considered an unanticipated hospitalization because it's 48 hours or more, it's unplanned, and it meets one of those 6 different diagnoses that's outlined in the definition. The second example is for Jim. He's hospitalized 3 days due to hallucinations. This is probably due to a psychiatric condition that Jim has. He's then discharged after those hospitalization, and he's readmitted 2 weeks later for the same psychiatric diagnoses. So again, that's under the readmission part of the definition. He is readmitted twice for the same condition within 30 calendar days of the first discharge, and each of those hospitalizations is 48 hours or more and unplanned. So that meets Part B of the definition. The third example is Jose is admitted to the hospital for 4 days due to bowel obstruction. Now, again, that would be a hospitalization MUI because he's there for over 48 hours. It's not planned. And again, it meets one of the 6 diagnoses. And then finally, Mary is prone to dehydration. Maybe that's mentioned in our Ohio ISP, but she's admitted for 3 days due to dehydration. Again, unplanned, one of the 6 diagnoses, and it is longer than 48 hours. So again, that meets that criteria for a hospitalization. Now, we know that a lot of people have questions about this, and we'll go over some more questions at the end about this. But the important thing I think as a provider to remember is that hospitalization for Part A does not get reported until you have discovery of it. So, for example, if someone is going to the hospital, that's not when you're going to report that. You may call the SSA and keep that person informed, obviously, but you're not reporting it as an MUI till you have discovery that it's met that criteria. So, criteria for Part A of the rule is the person's been hospitalized for 48 hours or more, it's unplanned, and you have a diagnosis of one of those 6 conditions, which you may not get until that person is discharged. That is when your discovery is. That is when it should be reported as an MUI. Then, following that, by 3 p.m. the next day, you should be sending in your incident report and that form that Chris reviewed. So again, there's lots of resources around how we'll implement this part of the rule, and we'll go over it more later, but that's just to give you kind of a high level of that. And next, we'll move on to talking about systems issues. In the previous rule, we had system issues identified. And so that just calls out that often when there's an incident, whether it's a UI or an MUI, there's a lot of different cause and contributing factors. This, we wanted to specifically call out that a systems issue should only be identified for substantiated neglect MUIs. We certainly know that there can be systems concerns or considerations for other types of MUIs. Like maybe there's a misappropriation and there was a lack of accounting. That might have been a consideration. But when we look at misappropriation, there is either an unknown PPI, a primary person involved, or someone that took that money or property. So we should only be seeing systems issues identified for the primary person involved or PPI for a substantiated major unusual incident for neglect. Next slide. When we talk about reporting requirements, again, providers do an amazing job of taking immediate actions after an incident, whether that be a UI or a major unusual incident. We want to make sure that we're documenting all those immediate actions, especially for incidents where, there's significant risk, like physical or sexual abuse allegations. We need to make sure that as providers, that we're documenting all those measures have been taken on the incident report so that is easily identified what has been done, not only to protect that person and any other person that may be a risk, but also that employee. In the next slide, we're going to talk about removal of a DD employee. You know that this part has been addressed in the previous versions of the rule. However, we took the opportunity during this rule revision to further clarify. So, and add in some additional supports. As Scott talked about, part of this rule committee was looking at how can we improve a very strong system. And in a lot of respects, we talked about how can we make this more of a learning process? How can we improve and enhance the communication among all people? And we heard from our direct support professionals that sometimes when there's MUI investigations, they're not aware of what's happening. And that's concerning, especially if maybe they've been placed on leave. So under the removal of a DD employee, we wanted to clarify that when someone is placed on leave, and that's required for allegations of physical and sexual abuse alleged against a DD employee, that person be provided the name of someone in their provider agency whom they can direct any kind of questions about during the investigation. So let's say Dustin is placed on leave. The person with their agency who informs Dustin will only share what the different what category the leave is being, what that person is being placed on leave. So let's say Dustin is being placed on leave for an allegation of physical abuse. As the provider agency, I can share, Dustin, I'm sorry, I'm gonna have to place you on leave for this allegation of physical abuse. I'm going to be your point of contact during this investigation that the county board is working on. And so if you have any questions during this process, whether you're on leave, please let me know. It's important that Dustin have that person that he can contact. Now, maybe that person is not going to be able to share a lot of information, but they can keep them as informed as possible. We do not want to share more than the type of investigation because that might taint the investigation. We don't want to share like what allegation was made, who made the report, and those kind of things. We definitely want to just keep it to that information, to the category type, and then let them know what they can expect. You're going to be getting a call from the investigative agent from the county board. Sarah's going to call you. She might set up an interview with you. Usually that's going to happen within this time frame. So keeping that person as informed as possible during the investigation, but not providing any kind of details. And we can go to the next slide. So we know that removal of an employee, a DD employee, also expands to a independent provider. So that could be a shared living provider. So when the removal of a DD employee involves an independent provider, we're asking that the county board identify a person that can direct that person with any questions or concerns they might have. And so this is just a new provision of the rule. Again, it's to improve the communication and experience for everyone going through that MUI investigation so they can ask questions. So that person or that contact at the county board may be the investigative agent, it may be someone else. But again, they're working alongside, the team during that investigation. We also added in the third bullet that, or the second bullet, that the county board, in addition to keeping them apprised of the investigation, that a county board has the authority to remove an independent provider from direct contact with any individual. So if Chris is working in multiple counties, if the sexual abuse allegation involves one person in one county, there's still the potential for them to be removed from any person they're providing services to. And that is protection for the person that they're supporting. Not only that person, but other people they're supporting, but also for that employee during the course of that investigation. So again, we wanted to provide more clarification on that. Next slide, please. And I believe I'm turning this over to Chris.
I think that may be me. Thanks, Connie. So these next couple of slides provide information on abused or neglected children incidents. So in summary, we know the difficulty in some counties getting information from Children's Services when they are the lead entity. If you're not getting any type of investigation report from CSB and limited verbal details, just know we understand and ask that you place any known information into the investigative report and do the best with the team to address cautionary factors and prevention. If CSB investigated, again, there is no expectation that the IA needs to conduct interviews for CSB-led investigation. So much of the same thing that we've kind of done previously and currently, but we just made it a little bit more clear here in the rule. When the Public Children's Services Agency notifies the county board that it has declined to investigate, the county board will initiate the investigation within a reasonable amount of time based on the initial information received or obtained. So again, in summary, once known that CSB is not taking the case, investigative agents, go ahead and proceed with your administrative investigation just like you do in any other type of abuse or neglect case. Notification requirements for MUIs. So staff of an agency provider will inform the director of operations or administrator of the agency provider within 1 working day following the day staff become aware of a potential or determined MUI involving misappropriation, neglect, physical or sexual abuse. So basically with this slide, terminology changed from informing senior management to director of operations, and from 2 working days to 1 working day. This, we feel, will allow the director to be made aware more promptly for those misappropriation, neglect, physical and sexual abuse cases. Again, they may want to identify further immediate actions, possibly more prompt retraining. So that's one of the key elements to making sure that the director of operations is informed, again, within 1 working day. General investigation requirements. All major unusual incidents, Category A or Category B, require an administrative investigation. Administrative investigations will be conducted and reviewed by investigative agents. So again, really not any change here. Basically, we're just reiterating a reminder Incident reports submitted to the county board by 3 p.m. the next working day, kind of the same thing. Category A, those cases are still initiated no later than 24 hours. In category B, no later than 3 working days, same as the current rule. The IA will make sure the MUI is properly coded, resolve any outstanding questions or concerns with the individual's provider and/or the individual's team, identify the contributing factors, and address the prevention plan. Again, general investigation requirements. So current rule indicates except when law enforcement or children's services is conducting the physical abuse or sexual abuse investigation, the IA will endeavor to reach a preliminary finding regarding allegations of physical abuse or sexual abuse and notify the individual or individual's guardian and provider of the preliminary finding within 14 working days. All right, so that's kind of what we got set up now. New rule, as you can see highlighted here in the red, now also states when not possible to reach a preliminary finding in 14 days, the I will instead notify the same people, again, the individual, individual's guardian, and provider of the status of the investigation every 7 working days thereafter. All right, so again, we want the communication to continue for these types of cases so everyone is updated in regards to where we're at with the investigation. And I think I'll pass it over to Dustin.
Thanks, Chris. Just picking up where Chris left off for general investigation requirements. And if you haven't already, I hope you are throwing a little bit of a party. We've changed the requirement from 30 working days to 45 working days for those investigative agents completing your reports for those administrative investigation and reviews. So current rule, 30 days. And what we've done is we've added 15 extra working days from the submission of the report. You know, the caveat here is obviously things happen, law enforcement may get involved, CSB, there may other be factors too. And so there is still that good process we have with extensions, and those will still be granted, you know, upon, you know, the need for more time to conclude those reports. And this timeline applies to county boards, COGs, and DCs. So when we think about disputing the findings of a written summary, we've already been doing this, and so it's just added and clarified here in the rule. And I'm looking at specifically when folks may dispute the findings of written summaries. And we're basically saying here, except when the primary person involved is an independent provider or the owner, director of operations, or administrator of an agency, those folks would not be able to dispute the findings. And again, that has not changed when you're identified as a PPI. So we're looking at, you know, individual's guardian, another person that the person has identified. And, you know, that is to really keep in mind is that process and helping folks through that process if they have questions or concerns about, or if they want to dispute something, they have 15 calendar days following the receipt of the filings that are sent to them. When we think about our review process, when we think about preventions and closure of MUIs, the department is now going to review and close additional major unusual incidents, and those are listed here. So the regional managers, folks here at the department, all of us, we're going to be looking at those attempted suicide MUIs. We're going to be looking at those failure to report MUIs, and then we're still going to be looking at what we consider as previously verbal abuse, but those emotional abuse MUIs. And the shift here is we're taking on those for our review process for that final closing, and county boards now will be able to review peer-to-peer incidents in full and close those out. Analysis of MUIs for our independent providers. Again, excitement here for kind of alleviating some administrative burden, are no longer required to do annual analysis. And so we kind of think about that process. We have great collaboration in the field. Folks know each other. They work really, really well. And we're going to continue to support one another, working through those team processes to ensure, you know, people's plans are addressed, those risks are associated with any trends and patterns and so forth, and make sure that our folks are highlighted and spotlighted appropriately and in real time for what they're going through and all those good things identified in those plans and through team discussion. When we think about more requirements, we think about UIs. And so this is another lift when we think about the administrative documentation burden is now providers, they still have to maintain those incident logs monthly, reviewing for trends and patterns. However, we're not looking to do a quarterly submission of UI logs to the county board anymore. Now this is more geared towards upon request. And this will be, and we'll hit on a few slides ahead. It's going to be the same thing for the department, requesting logs from county boards. The thought here is this should be reserved for if there are compliance questions and concerns. I know there's a lot of great practices out there. You guys are doing it really, really well. And again, for this, we should probably think about how to get away from, weekly or monthly reviews because we were kind of going above and beyond for quarterly. And now we kind of take a step back and shift our focus to really how do we support? We're helping folks in a different way, reserving the requests for logs. Again, more when we have compliance issues or maybe there are concerns about an investigation and we might have to look a little deeper. Again, we're alleviating the quarterly and again, upon request. When we think about our logs, whether or not there are any incidents for that month, we are still going to make a notation on those forms. They're still going to be looked at monthly by a provider. We're going to be making sure that we've addressed any trends and patterns. And so regardless if there's any incidents or not, we're still going to make that documentation full, sign and date, and make sure that we've truly identified, those trends and patterns and or that we're capturing those documents. That's still going to be a part of the provider compliance follow-ups and oversights. And when folks are having on reviews, those items are still going to be looked at as normal. And so continuing on with the requirements for UIs, again, there's some great teams all across Ohio, and we're making sure people's plans ensure risk are associated within those plans. Whenever there's an unusual incident, again, this is not meeting the requirement of the A part where one of the 6 for 48 hours or the readmission. We're still going to review those unusual incidents and make sure that, everything has been done to address the causes and contributing factors and that we got a good prevention in place to mitigate future hospitalizations and to really support that person in the full scope. Again, all providers have to maintain that unusual log monthly. And again, they only need to submit those to the county board upon request. And I believe with that, I am going to turn it back to Scott.
Appreciate it, Dustin. Thank you. Want to continue the kind of conversation about oversight here. This is kind of reiterating some of what Dustin talked about, but want to make sure we're clear. So county boards did not have to review those UI logs on a quarterly basis anymore, but can request them at any time. So the importance of them is still there. You want to make sure we're doing a good job as providers of maintaining those logs and having it there. It's just not that ongoing routine requirement, but can request them at any time. The UI logs will still be reviewed during compliance reviews. So we want to make sure that that's understood. Those are still going to be something that compliance is going to take a look at, to take a look, make sure we're identifying patterns and trends and trying to make sure we're getting out in front of, anything that's happening routinely to folks via UIs. And then again, the department will no longer be reviewing the county board operated programs. That's something that, has been in process, but once again, in taking a look at resources and trying to look at how we can be more efficient and more effective, we can certainly, if we have an issue, check that out, but we're no longer going to be requesting those on a quarterly basis either. All right, we got just a few more minor changes here, and then we're going to get to some questions for you. But so the first one here is talking about board members, and we do get quite a few questions here at the department about training for board members. This is clearly going to let you know that we want board members to be trained within 90 days of their appointment. But there is no longer an annual requirement for board member training. So folks just are always interested in the specifics about board member training, and hopefully this will help clear that up for you. The second bullet point here about UIs, I think you guys remember in the current rule, we have UIs kind of discussed within the the boundary of the rule. There's a lot of stuff that talks about UIs. And so for this rule, we decided to describe that in the Appendix F of the rule. So that will be a change. When you're looking at the rule, you're going to see an Appendix F that really takes a look at UIs and UI requirements. And I guess I want to reiterate, Connie did a great job of talking about the unanticipated hospitalizations. And one thing I wanted to just reiterate again, all hospitalizations are important. We took the opportunity to carve out the ones at CMS and the ones at our docs and the ones that we see as most preventable and that are most significant. But anytime somebody goes in the hospital, we all know this, it's a big deal, right? And so even if it doesn't fall in this line for an MUI, even if it's not a readmission that falls into the line of an MUI for review, providers of service are going to step up and going to do a good job of doing that unusual incident for the hospitalization and doing a really thorough job of trying to prevent that. One of the things I really appreciated from the stakeholder meetings that we had was the way that providers talked about their systems and their process and their ability to really do a good job of those unanticipated hospitalizations and making sure they follow up. So the moral of the story is if somebody goes in the hospital, it's important. It's going to be addressed as a UI with good cause and contributing factors and prevention, or it's going to be addressed as an MUI, with good investigation, good follow-up, and good review through our investigative agents at the board. So I feel like that really gives us an opportunity to really work those unanticipated hospitalizations into a place that makes sense, based on the numbers that we looked at and based on the amount of work that's responsible for providers and boards, to really delve in deeply here. So next slide there. Some specifics on the actual incident report itself, and we've talked about this a lot, just hadn't maybe had it always included in here, but you guys know that the incident report is critical. I mean, that kicks off, whether it's just a UI investigation or it's going to end up being an MUI, that information that reporter includes on that incident report is critical. And we want to make sure that we have some good information there. We want to talk about the date and the time that the incident happened, a really good description of the incident. And I know sometimes that's hard because it just happened and you're busy and you're helping people, but taking as much time as you can to try to include the who, the what, the when, and the where, the detail, because a lot of times that's going to really help, especially if it's an MUI investigation, that's going to help that IA to have the background and the information that they need to kickstart that investigation in a way that makes sense. And if it remains a UI, as a provider, you want that information to make sure that you can make sure you're doing your level best to prevent that from happening in the future. So some specifics related to that. We defined service and support administrator in our rule. We've all known that, but it wasn't officially defined, so that was added. This particular rule eliminated the requirement for an agency provider to submit the internal review of an MUI to the county board within that 14 days. There's, again, a lot of conversation about resource and follow-up, and was agreed that this part would be eliminated. In addition, county boards are going to no longer be required to send that ICF full administrative investigation report. And again, these were changes based on conversations with providers, ICFs, IAs about the follow-up related to these two items. And then the last bullet point here, to address our increase in attempted suicides and suicide deaths, we have an investigation protocol that's been added for those. And as we mentioned earlier in the presentation, our staff are going to be taking a look at those attempted suicides and obviously those deaths involving suicide, simply because we've seen clearly since I think the beginning of the pandemic, a pretty strong increase in attempted suicides and suicide deaths across Ohio. And that increase is not just within our system, but certainly statewide and also nationwide, if you looked at this kind of data. So it's important. I am happy to report that within the last 6 months, we have begun to see a decrease in the number of attempts and certainly in the number of deaths as well, which is good news. And we're certainly hoping that trend continues, but it is important, and we want to make sure we're dedicating the time and attention to these kind of cases because of the nature of the mental health concerns that are out there involving attempted suicides and actual suicide deaths. All right, moving on to some timeframes. When we talked about the agenda, we talked a little bit about the timelines that are coming, and we mentioned the rule effective date is July 1, 2025. And again, as we described, we're still doing a lot of training. There's a lot of great questions coming in. We're really taking the time to address those, to follow up. There's a lot of resources that are being put together. You've heard from some of the presenters today, our frequently asked questions, our interpretive guidelines, questions that we get today in this training, questions that we've received in previous trainings. We're trying to address those, capture those, and trying to make sure that we get out in front of those questions for you guys. so that we are as prepared as we can be for that July 1 start date. So certainly some changes going on within our system, some changes going on with OITMS. All of those things have required us to do a lot of collaboration within the field to make sure that we're ready to go. So as I mentioned, a lot of in-person trainings, these kind of virtual trainings, resources in Q&A, FAQs, interpretive guidelines. All this information is going to be available to help us be prepared to roll this out. So with that, this is going to conclude the general information that we're sharing about the rule revisions. What we have put together was, again, some frequently asked questions from previous trainings. So we're going to run through some of these and have you have some conversations. And we have been checking. I know that there's been a lot of good questions coming in. We're going to go through some of these, and we're going to try to include some of those good questions that you guys have been asking today as well, because we have some time left to cover some questions. So I'm going to turn this over. I think, Connie, you want to take over for the FAQs here?
Absolutely. Thanks, Scott. So, and thank you again for all the good questions. I think we've fielded almost 60 or 65 questions, so great. So the first one is, what happens if the hospitalization is not on the description list? And what we would advise people is that would be considered a UI. And so the provider at the time would write the incident report like they do now, and then there would be a UI investigation. We've had people ask through the chat, what happens if someone goes to the hospital or they're in the ER and for one of those conditions? Well, if they're in the ER, let's say for dehydration, but not admitted for 48 hours or more, then that would too be considered an unusual incident. The next question talks about, does the provider wait 48 hours to report an unanticipated hospitalization? And yes, we would ask that you do that. Obviously, reporting an MUI is different than communicating with the team or coordinating with the team. What we're talking about here specifically is reporting of an MUI. And so that again is different than talking to the guardian, the SSA, but we wouldn't expect those reports for a MUI hospitalization to be reported until the criteria is met. So that's, 48 hours or more, unplanned, and a seizure. Or it's a readmission for within 30 calendar days of the first discharge for the same diagnoses. So again, we want to make sure that people are reporting and reporting timely, but it's on discovery of the MUI criteria being met. I think Chris went over this really well, but providers are required to submit incident report forms by 3 p.m. the day following their discovery. And that also includes for hospitalizations, unapproved behavior supports, and law enforcement, those forms. And then I think Dustin's trying to make me seasick. The provider is the one that's generally filling out and completing those forms for C, D, and E. So if it's a hospitalization, or let's say a unapproved behavior support, those are going to be completed by the provider at the time of the incident. Now, there is a chance that there is a law enforcement MUI, and a provider does not have to be present for that to be investigated as as part of one of these new administrative reviews. And so there's potential that an SSA may need to complete the law enforcement form because that person may not have a provider, and they might discover that that person was arrested. So for those administrative reviews, again, it's the provider completing the form if there is one. In the case of law enforcement, it may be an SSA or another county board employee. And this came up in the chat as well. Would you complete an incident report for all hospitalizations? And that's yes. Um, if it doesn't meet criteria, then it wouldn't be an MUI, but it would still be considered an unusual incident, and an incident report should still be written. In terms of EpiPen, because that was removed from the definition for a medical emergency, the question has come up, do you need to write an incident report for that? And the answer is no. You would capture that on the medication administration record just like you would any other prescribed medication. And we're getting a lot of questions, like Dustin said, about emotional abuse and what creates a hostile environment. And I think he provided a really good example, but sometimes there are situations we know that maybe didn't fall under the definition of the previous verbal abuse, but we knew we're wrong, like that we're causing an individual a lot of distress. And so, again, those are situations where someone's being bullied repeatedly, or putting them in an unsafe, leading to an unsafe or fearful kind of situation for that individual. I think for those types of examples, we're really going to need to talk through those. So if you have a question about that, please consult with the MUI department at the county board or at the department, and we will be happy to talk through those situations with you, as these are kind of new. The other thing we've been asked is, does there have to be intent for emotional abuse? And the answer is no. So there are times that people act a certain way that may cause stress to a person or put them in an unsafe environment, those kind of things, where they do not believe they're causing that person, or they do not believe they're being emotionally abusive. Um, while there doesn't have to be intent, that will be considered through the investigation. So we just wanted to be clear, there does not have to be intent. But again, we would look at that definition, you know, and again, that's, as the person used actions, words, gestures, or a pattern of behavior that creates a hostile environment, and or is that used to purposely threaten, intimidate, coerce, or harass that individual. So we'll look at those cases, more specifically as we have details, because there could be a lot of questions about what does that look like. And we'll want to kind of reserve that for when we have the details around that case. This QR code will take you to the Health and Welfare Toolkit on our website. This is where you'll see that new posted tile. Hopefully by the end of the day, it will be up and available for you, and it will include all the things like the frequently asked questions, interpretive guidelines forms that we reviewed, a copy of today's PowerPoint presentation, the taped webinar. And as we review and have more resources to share with you, we'll put them in that spot. And so that is available for you. And I think, Scott, do we want to take the time to get through some of the questions in the